Hello everyone. Today we will be knowing about the CAR T cell therapy. Have anybody came across this term before? No. Okay. So today we'll be knowing it. What is CAR T is this term I'll be using in whole of the slide. So I'll define what is CAR. That is chimeric antigen receptors. It's a kind of receptors found on the cells, every cells, and sort of normal cells also. And this is a modified antigen. The therapy is modifying this antigen, so it comes under immunotherapy. That's what I have written. We will be exploring the advancement in the immunotherapy. So shall we go? Okay. The first thing is chimeric antigen receptors are genetically encoded artificial fusion molecule reprogram the specificity of the peripheral blood polyclonal T cells against a selected cell surface target. I need a quick thing. You have came across T cells and B cells, T lymphocytes and B lymphocyte. So what it does? Huh? Yeah, it kills. So it's like remember this cells like T cells and B cells are the immune defense system basically. The thing here what we are saying is this chimeric antigen receptors are genetically encoded where in the lab we collect the blood from I'll be showing the process how it will be working. Okay, so you got the definition what we are doing. The second part of the definition says like CARs are genetically engineered receptors that combines the specific binding domain from a tumor targeting antibodies with T cells. Signaling domain allow the specifically target antibodies redirected T cells activations. Let me just imagine there is one an assigned assassination. You know what's the term assassination? The assassination is you give the photo of a person, give a money and say to kill some person. So this is what happened in this cells. We are getting the cells and we are training, we are engineering it genetically and we are again infusing it into the patient where it finds the target cells like cancer cells, tumor cells and it will kill. Got my point? Okay. This is the definition. Second part of the definition completes. Now, how did it start? Yeah, every discovery was an accident. Is it? Penicillin was an accident. So here, this discovery was also an accident. It's an immuno based. So it was first discovered in Weizmann Institute of an Science, created an first chimeric antigen receptor. The story was big, so I just quite shortened it. One scientist was there. He discovered a chimeric antigen receptor for something else, to do something else, but it was very useful in the tumors, to kill the tumors. Okay, I can also ask you the definition of tumor. What is tumor? Huh? Mast cells, yeah, abnormal growth of a cells. Very good. That's a tumor. Okay, so basically the drug was very much, not drug, kind of therapy. It was very much effective towards the tumors. So in 2010, what happened? The first successful cancer treatment with CAR T was for an advanced follicular lymphoma patient and was reported by the lab of Steven Rosenberg. Okay, it's a large laboratory, Steven Rosenberg in USA and as well as in global. So they tried on the cancer patient with follicular lymphoma and it was very successful in 2010. Well, coming to the 2017, a drug was launched by FDA. The drug name was Kymra, was the first CAR T cell immunotherapy approved by FDA. It was approved for children and young adults aged 25 under who relapse or were not responding to the therapy for acute lymphoblastic leukemia. If I ask you, whereas in one situation where chemotherapy and immunotherapy both are different, okay? So immunotherapy and chemotherapy, which will have more relapse, remission, which will have reoccurrence of the cancer again and again? Chemotherapy. So for that thing, this was very beneficial in the terms. Okay, got this? I have very less slides. Okay, please be connected. We will finish early. So it where all is available. It's available globally, like China, Europe, Canada, Australia, UK, England, Scotland, and several other countries. In India, it came at 2021. It was first used in Tata Memorial Cancer Center, and it was very successful in bone marrow transplant unit. Okay. Now, as I said, we will see the process, how it gonna. Can anyone be just say what happens in chemotherapy ward? What happens? Patient comes, and you don't know. Okay, chemotherapy is the thing is chemicals or drugs dossier. We will adjust the dose. We will be infusing it. It is common in immunotherapy and chemotherapy. That's the common thing. But here what happens, we are first preparing the patient like prior 5 days, then on the first day, like here like -5 3 like that it runs. On the first day what we do, we collect the sample. What's the sample? T cells are extracted from the patient own blood. Okay, T cells are only T cells we are extracting. Then what happens, we will do the modification. A special receptor gene is lab engineered into the T cells to target and bind cancer cells proteins. This is a long mechanism. I'll be explaining which are the receptors and how it will be identifying and getting attacked. Sounds interesting. Some drug is identifying the receptor and binding to it and killing the cells. Okay, the modification. The third phase will be infusion. The modified T cells are re-infused into the patient where they identify and attack cancer cells with precision. Okay, what are the three phases? Just give a glance: collection, modification, and infusion. Okay. Every other treatment has an obstacle, isn't it? Or else we could be having only one antibiotic that will be sufficient. But we are coming across all the obstacles, and we have another antibiotics. That's how it comes. So here also we have like identifying unique antigens on the solid tumor surface has largely failed with targets like EGFR8, yeah, Li13R alpha 2 and HER2 providing difficulty. Okay, it's because due to some kind of microenvironment surrounding the receptor. Like in terms of solid tumors, the surrounding microenvironment, ECM and HPSC actively suppresses the immune response, limiting CAR T effectiveness. Let me say you, this therapy is like immune. Basically, it's boosting your immune and going against the immune. So immune will won't be quite. It will also try to suppress or try to avoid it. Okay, so that's the obstacle coming. The mostly second part of the challenge is you have collected the sample, you have modified it, but the challenge comes is to infuse. Sometimes what happened, rejection. That rejection is known as graft rejection. So there is a certain protocols for it in every studies, which are confidential in all over the studies. Like it's different peoples or different kind sort of demographics, they will have certain protocols. This protocol is like generalized one. Why the rejection happen? Because the host immune system recognize CAR as a foreign antigen, CR antibodies, as I said. The second point, inadequate lymphodepletion. Native T cells destroy CAR T cells. Okay, lymphodepletion, lymphocytes. Okay, the B cells. B cells, if the depletion are not happening, this B cells will activate the T cells which are already present in your body, and that T cells will attack this engineered genes. You're getting my point? Okay. The third thing is tumor antigen losses. What happened? The tumor will get attached. Antigen, it loses the property. It's supposed to kill, but it's going and it's like kitty party. They are joining and they are just enjoying. It's supposed to kill, but it's not killing. The T cell exhaustion. T cell, it happens in the immune therapy most of the time. The cells or the therapy which you are giving, the immune system which already present in your body will exhaust that. It doesn't have any properties. Okay, high tumor burden. Okay, this rejections, that's what how rejection, why rejection happens. Okay, the second, prevention protocol, we have to prevent, right? To success the therapy we have to prevent some of the other situations. So properly lymphodepletion, avoiding drugs that kills CAR T cells, reducing tumor burden. Okay, these are three prevention strategies we can use it. The first strategies is proper lymphodepletion. Given, as I said, we are preparing the patient before before collecting the blood. Also we are preparing the patient. So minus fifth day to the minus third day before infusion, the regimen of fludarabine 25 to 30 mg per square meter per day into 3 days. Okay, and along with that cyclophosphamide 300 mg to 500 mg per square meter per day for 3 days. So what it does, it eliminates the host lymphocytes, prevents immune rejection, improve CAR T cell expansion, increase ILT and IL-15 T cell survival cytokines. Cytokines has major role in this. I'll be explaining in the last few slides what is the role. Like cytokine must be released in a limited count. If the count increases, it will lead to another syndrome, another sort of disease. Okay, the second strategy will be to stop before infusion the systemic corticosteroids. Can anybody say what is any systemic corticosteroid? You know, yeah, which will be, yeah. Why we are avoiding it? Yeah, inflammation. Yeah, anti-inflammation. Exactly, inflammation is because of immune response, isn't it? Okay, the ATG and calcineurin inhibitors, high dose chemotherapy, they destroy infused CAR T lymphocytes, which fails the therapy. The third is to reduce the tumor burden, bridging therapy. That is low intensity of chemotherapy. We are reducing the dose of chemotherapy. If the patient is going on chemotherapy and we are shifting to immunotherapy, then we are lowering the intensity of chemotherapy, targeting therapy like ibrutinib in lymphoma. It target therapy, we use this drug. So what happens if it is having high tumor burden? High tumor burden will lead to faster CAR T exhaustion. एग्जॉस्ट हो जाता, मतलब it can't do it work on the site. Before it reaching to the site, it will be too exhausted, can't do any work. Okay, and what happens, it's functionally rejected. What's my point? Yeah, this how we overcome. Okay, we have finished the definition and the process and the challenges. This is the process, like quite diagrammatic way. You can see here the phase 1. Can you see? Yeah, here collected T cells from patient, then what we are doing, T cell activation we are doing, and we are antibody coated beads we are using. That's the process. It's totally uh, microbiology or biology, biochemistry. Then what happened, T cell engineering we will develop, then T cell multiplied, then infusion, then CAR T cell will be injecting, and the sixth phase you can see CAR T cells against reoccurrence. If reoccurrence happens, in this also reoccurrence happens. It's not like that once the patient go through the immunotherapy the cancer will almost destroyed. So it will be reoccurrence. That's the process. This is the structure. I won't take much time in this, just quite to understand you. This is ectodomain and endodomain. What is this? What is the structure? This is our chimeric receptor antigen. Okay, this is our chimeric, and we are discussing about this only. Actually, these are the parts. This is the signal. This is like a blade. You know, you have seen more 90s movies. They used to keep some blade which opens like this, zig zig. You have seen. It's like this. It opens like this. It connect to the cells. Okay, okay. Let's come back to the topic. It opens like this, it linked to the cell, it drags and it destroys. Got my point? Sorry. Okay, let's focus. This is the linker, this is spacer. Spacer is nothing but uh, spacer makes a T cell activation. This here it doesn't have any T cells actually. It's just a defense for this. We have T cell activations in this endo domain. Endo domain has T cells which we modified. So here you can see actually here it attached and it is activated. It's like destroying the protein bounds of the cell. This is the cell layer, cell membrane. Here the cell layer and cell membrane, it destroying the proteins. Okay, and these the protein bundles. Okay, this is the structure of the CAR T cells, common structure. Let's see the receptors. We also have generations in this. CAR T cells has a generations. The first generation is like lesser strength. This is the first. To keep differences, there is 1, 2, 3, and this is a separate one. But this and this is not same. Here the first CAR T generation, it has a smaller length, as you can see. It can just affect this part of the region, not whole membrane. The second generation, as you can see, this is little bit longer than this. So it affects all like surrounding, much of the more surrounding. It has actually a functional difference also in generation 1, 2, 3 and the truck. Truck is not truck. Truck is like I have used much of the short forms related to automobiles, but the thing is truck. Okay, truck is the four thing, like this is more than this in the range compared to this, and the fourth is it's along with the cytokine. The cytokine is which are defending the CAR T cells. We are including that in this, and we are sending. It's like the people who disturbs you most of the time, you mingle with them and you get attached and you destroy that. They destroy the bond. Okay, okay, it's like this, it's like that. Its cytokine itself is the villain for CAR T cells, as I can say. So it's, we are joining it and we are sending to the membrane where the immune system cannot recognize which cytokine it has to kill actually. Okay, discuss. These are the cytokines are releasing from the cells. Got it? Diagram. Any doubts? Like a car and truck you applied that? No, sir. There is a terminology. It's T cell redirected. Actually, the truck stands for T cell redirected for universal cytokine killing. Sounds good. It's T cell redirect. We are redirecting the T cells for universal cytokine killing. And this is pie chart I have used to show कि most of the this one CAR T cells, which receptor it's affecting is CD19. Where we can find the CD19 in which type of cancer? CD19 receptors. CD19 ALL actually, acute lymphoblastic leukemia, and CLL, chronic lymphoblastic leukemia, where we find this sort of receptor CD19. And so now you got the point कि this therapy will be effective on ALL and CLL. Okay, structure of CD19. This is a structure, basic structure. This you can see like antigen is getting attached to the receptor. This is the receptor one, where this is the closer version. It's not clear. It's a closer version. Okay. I am showing you in this because the next I will be playing a 5 minutes of video in this. So you won't get this type of diagrams. Ah, and the major difference, okay, I forgot. This major difference is, as you can see, it's just one time it's coming to the cell, and it's nowhere back. It's not attacking back. It's just coming and killing the cell and finish. And the CD19, you can see the target CD19, where this type of bundle you can see, it's like four time of it's like cutting the wall from four ways. It's like first this, then this, second, third, and fourth. Okay, this is the difference. You can just see. This is the structure of BCMA. What is BCMA, guys? Is B cell maturation antigens. Antigens, okay? It's B cell maturation antigen. Why I'm explaining you this CD19 and CD20 and BCMR? You might be thinking where I started and what I'm explaining the receptors. Actually, these are the like signals. The CAR T cells needs a signal to find there. We are multi-cell, right? We have like multi cells, many of the cells, many of the networks we have. So which cell to it has to attack and where it is present, that signals will be given through this receptors. What are those signals? Like CD19, it's CD19, actually it's a glycoprotein and target antigens. This has a B lymphocyte as a co-receptors. So this B cell activations will give signal to CAR T cells to attack on that cell. Okay, and the CD19, they are the mature B cells and malignant B cells. They are not found in CD19. Wait, let me go. CD19, these are not found in stem cells or plasma cells. Okay, and BCMI, as I said, BCMI, it releases. So the myeloma cells will has this activation. This is a myeloma cells. Okay, it has a BCMA that releases, gives an signal to the cells to attack on them. Okay. The next is HER2. This is very common, we have came across, right? Human epidermal growth factor receptor. These growth factors will be the signal to CAR T cells. So highly expressed on the cancer cells, easy for CAR T cells to recognize and kill the cells. Okay. These are the few clinical trials and their summaries, what happened in previous years. By August 2017, approximate of 200 global clinical trials were underway involving CAR T cells. 60% of the trials focused on hematological malignancy, with 80% targeting B cell cancers using CD19 CAR T cells. By 2016, studies expanded to explore alternative antigens like CD20. Like I said, there's a side effect for this. If the cytokines are releasing in more in numbers, then it causes like cytokine release syndrome. CRS cause a rapid and massive release of cytokines into the bloodstreams, triggering dangerous heavy fevers and sharp drop in the blood pressure. Like one patient we came across, the patient is having hemophagocytic lymphohistiocytosis. It's, as you can see, it's here. Okay, it's severe symptom. So what happens in this symptom is the patient will have swelling, inflammation all over the body. Inflammation will be seen. So severe symptoms will occur in this therapy. This is the side effect of this therapy. More other side effects are there, like neurologic toxicity will happen, that is due to immune system will be disbalanced, so it will be aphaxia, that impairment of ears, and confusion, delirium, involuntary muscles and hallucination, unresponsiveness, and seizures. The second, B cell aplasia. What is aplasia? Aplasia, B cells. Okay. R stands for the kill, right? Aplasia is like the CAR T cells targeting B cell surface antigens, destroying both the cancers and healthy B cells. Okay, you got my point. B cells, those are in cancer cells, those also killed, and the healthy B cells also killed, leading to B cell depletion. If B cell depletion is there, then it leads to decrease in the activation of T cell. B cells are the core receptors which helps T cells to fight against the foreign body or sort of any kind. The third will be tumor lysis syndrome. Tumor lysis, a group of metabolic complications triggered by the breakdown of dying cells during toxic cancer treatment. That's what I said. Ki disbalance, metabolic disbalance or immune disbalance will be seen. Misbalance. Okay, anaphylaxis, life-threatening allergic reaction. Symptoms like hives, facial swelling, low blood pressure, and respiratory distress. Let's. This is a summary. What I have explained you. This is the summary in 4 points. CAR T cell therapy is a type of immunotherapy used to fight cancer with altered immune cells. Success rate is 30 to 40% for lasting immersion. I said ki in chemotherapy reoccurrence will be much more faster, but here it is like 30 to 40% for lasting immersion and with no additional treatment, according to the Michaels Bishop, MD, director of Chicago Medicine's cellular therapy program. Infusion time here is the infusion time for CAR T cells typically needs 30 to 90 minutes. Have anybody seen what's the chemotherapy infusion time? The daycare patients comes and do for infusion. Please, if you get the chance, you just check what time it will take to infuse. Okay. Then therapy cost here is drug acquisition. Drug acquisition is the largest component of the cost of CAR T cell therapy, with the list price ranging from $373,000 to $475,000, depending on the specific drug and indication. It will be very costly because we are involving many of the specialities in this, right? Developing, modifying, engineering, and clinical trials shows reimmersion rates up to 93% in the severe blood cancers. Patient requires minimum 7 days. These are drawbacks, kind of key facts. Patient requires minimum 7 days hospital stay post treatment. It is immune therapy that enhance the body own immune cells to fight against the cancer cells. Got the point? The total uh, overview, like I can say ki total narrowing the slides, narrowing the today's topic, it's like it's immunotherapy that enhance your own body immune cells to fight against the cancer. Okay, these are the benefits. Benefits are, like I said, it active in both the CD4 plus and CD8 plus T cells, target proteins, carbohydrates, and glycolipids, and rapid generation of tumor specific T cells. We can generate multiple times if we do it once. The minimal risk of autoimmune or GVHD, graft versus host disease, acts like a living drug. It's like living drug, requires only a single infusion. Disadvantage, yeah, as I said, cytokine release syndrome, cause high fever, nausea, and capillary leakage syndrome. Neurotoxicity we have seen, price also we have seen. So it's a let the whole what I have explained, I wanted to show in a small video. It's just small. Voice. The blue you are seeing, it's a tumor. The cells, CAR T cells. Okay, it's fighting against the tumor cells, cancer cells. This is from like microscopic. Now we immerse. These are the cells. As I showed you the structure, These are the structures. As you see that receptor CD8 and T cell receptor. Now it will get attached. See, now it's got attached from the foreign particle, T cell receptors. This happening in your cells in, like, everybody's cells has this kind of like fluctuating proteins and glycoproteins. It got attached there. Okay. Now we entered a cell. Actually, this is, actually there is some audio also in this. It's not connect. Understanding, huh? Okay. Okay, the next explanation is little bit different. You want to see whole video? I'll share. I'll share in the group. You can go through. I hope so. You all will see that video. I just wanted to show the part, starting part. Any question? These are one more video you want to see. These are the references I took, where articles and few of the textbooks. Then any QA? No question and answers. I'd like to take two, three questions, please. Huh? Key facts, huh? Yes. It's in the severe blood cancers. Very expensive. That's what I said. It's a drawback. Key facts. That's this also. You can see that 7 days patient has to stay post the treatment. Disadvantages. Any other? Any other questions? Fifth year, sir? It's not much cost effective. I think question was for me. Yeah, it's it. Okay. Any questions? Any other questions? Thank you, guys. Thank you.